Hi, everyone. I'm just, hi, Jennifer.
Is this the new link for instead of the Zoom one?
Are you on Teams or Zoom now?
I'm on Teams.
Right. No, I think we are still on Zoom.
Right, okay.
I will send you on the chat.
I've probably got the Zoom link somewhere else. It's been a while since I've been able to join, so I wasn't sure where we were. And this popped up on my calendar.
I think 1 second, I will just copy that to you. And here we go. If you
Thanks very much.
can switch, we'll see you on the other side. Okay, let me just open my camera. Hi, everyone. I'm just gonna start sharing. Can you all see the slides?
Yes.
Yes, we can see them. Yeah.
Oh, brilliant. Thank you. I think some people are still joining on Teams. Don't know. Right. So let's start. So that was a nice, interesting case a while ago, actually. So here we go. So that was a 23-weeker. Was in utero transfer from another hospital in Scotland, came to us. Mom was type 1 diabetic, had also ruptured membranes for a couple of days before delivery. Had completed antenatal steroids, Maxalf given as well. Then she went into spontaneous delivery. Baby was born in okay condition, responded to airway management, was intubated in delivery room, given surfactant, was good size actually, and then given to mom for some cuddles, and then went to neonatal unit. Baby remained ventilated for the next few days. Oxygen was okay, 23 to 30%. Had a repeated dose of surfactant on, I think, day 2 or day 3. Unfortunately, developed right-sided pneumothorax on day 3, requires a chest drain. Baby responded well, and then the drain was removed after 2 days. Had cranial ultrasound was fine, and on the continued obviously ventilation for a 23-weeker. However, on day 25, during that time, during the 25 days, had issues with late onset sepsis, suspected sepsis, some antibiotics, stopped trying to establish some feeds, went into a decent volume of milk. However, from the ventilation point of view, the oxygen continued to go up to 60%. At that point, we, after completing the antibiotic course, we gave the first start protocol. Improved slightly from the oxygenation point of view. However, went back during the course up to 80%. At that point, we stopped obviously the DART to make sure we're not missing any infection. Baby was cleaned, started antibiotics again, and culture was negative. Clinically, baby responded. So we give like 5 days antibiotics, and then commenced a second DART protocol, and baby was extubated during that time to DUPA on 40%. Continued on DUPAP for a few days, establishing feeds, baby clinically stable. However, after probably 4 or 5 days, oxygen continued to rise again, 60 to 70%. Screened, commenced antibiotics again. Blood culture grew staph capitis, although CRP remained normal. Day 55, rising FI2, again on DUPAP. At that point, we just reached like to 70% or 80% on oxygenation on DUPAP. At that point, everyone felt quite nervous to continue, so baby was intubated. And oxygen, instead of coming down, actually went up. So oxygen went up to 80 and then later on to 100%. And clinically, baby didn't look well at all. And in view of the previous culture of staph capitis, we recommenced again VANC and GENT. Baby had PEC line at that point. We were wondering whether this line was like 14 days old. Shall we remove the line and replace it? So we did that already. And then antibiotics changed from VANC and GENT to Mero because of the continuous deterioration. Later, we added linezolide just to cover for gram-positive sepsis. And then we continued for like 2 weeks on this situation. Baby intubated on antibiotics, CRP remained less than 6, and no improvement. I'll just show you some x-rays from like day 50 and day 55. This one on the left-hand side was when the baby was on DUPAP prior to reintubation. And you can see lots of x-ray changes. Abdomen looks okay, just distended belly, but the lung is not great. This is after intubation. Slightly better inflation, but again, there are lots of parenchymal changes. The tube obviously was a bit deep, so that was pulled back. Any comments so far from the audience? Any question you want to ask? Okay.
Tube is too deep.
Yeah, so we'll see.
I'm pretty sure it will move it out.
Yeah, for the tube, yeah, we pull it back. So from ventilation point of view, we continued on this kind of settings, and you can see already we're on decent pressures and decent minute volume. Trial of high frequency was commenced, not much difference. This is a blood gas. At that point, I'm just giving you kind of a range. So you can see it's compensated respiratory acidosis. O2 is slightly low. It's actually very low. And lactate is normal. So this is a picture of kind of hypoxic respiratory failure for a baby that we gave him already 2 courses of DART. He's not responding. So what kind of things we should do? Obviously, we'll do echo, we'll do functional assessment and see what's going on. So these are kind of the parameters of severity of hypoxic respiratory failure. Blood pressure was okay for this gestation. Baby was like almost 2 months old for 23 weeks. Oxygenation index is about 30, it's massive. Oxygenation saturation index is 13.7, the normal is less than 2.5. Saturation FiO2 ratio 91, normal is more than 350. So again, all parameters indicating severe respiratory failure. And this is the most important thing here. The alveolar arterial gradient was 590, meaning there is a massive diffusion problem with the baby at the lung level. So there is something going on with his lungs, which is not quite picked up on the lung, on the chest X-ray. And he had been treated for antibiotics for 2 weeks if there is any kind of infection or anything. Echo was done. I will show you some videos. Showed mild to moderate pulmonary hypertension, but function actually preserved. These are the kind of laboratory results. So hemoglobin 127 was 85, then baby was topped up. Platelet dropped to 36. And then white cell count was 11. I have to say as well that the baby had thrombocytopenia and leukopenia with neutropenia. Then we started to give him GCSF during that period, empirically, just to help if there is any late onset sepsis. And she did respond to that. So neutrophil actually came up from 0.4 to 3.2, and white cell count, neutrophil came up to 6.8 from 0.4, and white cell count came up to 11 from 3.2. And interestingly, CRP remained less than 6. I will show you the X-ray at that point. During that day, it was one of the weekends. And you can see babies becoming quite more edematous. And you can imagine the picture of a very sick baby who is muscle relaxed, on sedation, on ventilation, 100% oxygen. This is the PET line, good position. And I scanned that line tip, there was no clots or anything. You can see some parenchymal changes, but actually it looks slightly better compared to the previous X-rays. Abdomen, there is a paucity of gases, a very sick looking child. And we actually thought we're gonna lose this one. So what any thoughts about this one? We'll show you the summary of the blood investigations. Just prior to intubation and till the day I just show you the last X-ray, and you can see some drops here of hemoglobin. That's the lowest, obviously been topping up the baby. Platelets dropped to 13, and I remember those around those time we had actually to give platelet transfusion almost every 12 hours for this baby just to keep platelets up. I'll show you some echo pictures. This is on the 5th, the day prior to the severe deterioration, and you can see a reasonably well-contracting 4-chamber view, so well-filled, decent contractility on both right and left. There is no right ventricular dilatation indicating severe pulmonary hypertension. Septum is slightly desynchronous and flat, but that's what you expect in this degree of respiratory failure anyway. And there is no massive TR jet you can see. And in the parasternal lung axis, again, decent contractility. And that's kind of from eyeballing point of view. But now if you go to more robust assessment, we've done tissue Doppler. The LV S prime is 3.99, just on the low borderline low side. And I put here the pulmonary veins, and I will tell you why in the next slide. So pulmonary veins, actually, the S and D waves were okay. 24 and 25 is not bad, and you can see pulsatility that rules out in this particular vein rules out pulmonary vein stenosis. And that was a summary. Here we go. Ejection fraction was fine, and the numbers TAPSE was okay for a preterm baby during that period, 0.7. For preterm babies with this gestation TAPSE, which is an indicator for RV systolic function, anything between like 0.7 to 0.9, even up to 1 centimeter is fine. So it wasn't too low. The PAT and RVET indicators of pulmonary artery pressure overload was indicating pulmonary hypertension, especially the ratio between the PAT and RVET, and then the pulmonary veins, as I said. Okay, so we tried nitric because I'm sure most of you would have tried that, and actually no response whatsoever. So we tried the nitric, and you know, when you start nitric, and if there is a kind of a nitric responsive pulmonary hypertension, you will see that the oxygenation will improve dramatically and you will be able to wean FI2, but that wasn't the case here. Blood pressure started to drift down a little bit after the nitric, and then we commenced dobutamine, just a small dose, and blood pressure improved. And that was a repeat echo. So compared to the previous one, is slightly more hyperdynamic if you like. Baby was a bit more tachycardic, but contractility was okay, and filling was okay as well. And there was a tiny duct in the previous echo. Actually, I didn't put a clip for it, but because it was tiny, you can hardly see. But after the nitric, you can see it's kind of more prominent. It's mainly right to left, shunting a bit more blood. Again, PAT was essentially the same, but here, interestingly, the pulmonary veins were kind of almost doubled because of the nitric. So nitric will cause pulmonary vasodilatation, will cause increased blood venous return from the lungs to the left atrium and left ventricle. And you can see the velocity of S and D wave almost doubled, 58 and 60. And that could have contributed to the, because shunting lots of blood as well could have contributed to the blood pressure issues. TAPSE actually improved to 0.85. The tissue Doppler improved on the LV, and the PET remained the same. So here we have a severe hypoxic respiratory failure with moderate pulmonary hypertension, with preserved function, maybe non-responding to nitric, and we're not winning. So what any suggestion from the team here? Any thoughts?
You obviously VQ not a 1.
Yeah, so there is kind of VQ mismatch, I agree. And there is a diffusion problem from the alveolar arterial gradient because it's very high. But what can you do? Like, what else you do just to get more information? And any particular thing you picked up on the lab?
What about the viral studies? Did you do?
Yeah, good idea. So we sent ET secretions for virology and for also microbiology, and I will tell you in the next few minutes. But there was no COVID, no RSV, no kind of the common viral things.
So unusual bug?
Yeah, pretty unusual bug.
Like Gammatiscarini or something like that?
No.
Was this child on antifungal prophylaxis throughout her treatment?
Yeah, good point, Tosin. So yes, he was. She was on fluconazole prophylaxis, and actually we switched to treatment dose during that period when she was critically ill, and we sent fungal cultures and urine, and nothing came like positive.
Did you see all the pulmonary veins on your echo, and did you consider doing a CT to rule out pulmonary vein stenosis? Yeah, good point. So I put only one of them, but there was no indication of pulmonary vein stenosis as well. And this is really a good point because we know from literature that pulmonary vein stenosis, even if you have a normal echo study on the first kind of few ones, this can be a progressive one and can develop later on as those babies grow. So yeah, all repeated echoes had a comprehensive study and there was no indication of pulmonary vein stenosis.
How about an interstitial lung disease screen?
Like?
The genetic panel, although of course you're dealing with an extreme preterm, we know these babies do get very severe lung disease in this setting, but I think it's always still useful to think about doing an interstitial lung disease panel.
Yeah, absolutely. It's I think it's a very interesting thought. I have to admit, we didn't think about that during that point. We kind of, the thinking was like, it looks like infection somehow, but I think it's a good idea, Tosin. Possibly we could have sent like, the respiratory genetic panel, alpha-1 antitrypsin, CF, and the interstitial lung disease as well. Good thought, yeah.
Did you look for the uroplasma or mycoplasma?
Yeah, again, good thought. We didn't send for that, but what you could have done just to pick this up if there is any ongoing infection on the lungs?
Any blood or secretion aspirated from the ET tube?
Yeah, so we send the secretions and it grew something. I'm just trying to make it more suspense. Okay, so I will tell you now. Right, so what we done at that point, we just did lung ultrasound, and I'm sure most of you know about lung ultrasound, but just a quick reminder, this is how normal lung ultrasound looks like. The pleural line, very echogenic, bright, thin, and then A lines are transverse line at equidistant space, and this is kind of normal aerated lung. On the other side, here on the right panel, this is a lung of chronic lung disease picture. You see the pleural line is quite thickened and hazy, sometimes interrupted with small subpleural consolidation, lots of coalescent B lines, those white things here. And you can hardly see any A lines. There is a small kind of faint A line obscured by lots of B lines because of interstitial fluid. This is how like chronic lung disease should look like for a similar baby. So we've done lung ultrasound on that particular day just to see if we can get more information. The X-ray wasn't telling actually the whole story. And look at this. So that was the L3 is the left lateral zone. You see lots of consolidation here, actually large consolidation, air bronchograms, those white speckles coming and going. These are dynamic air bronchograms in particular. There is shred sign around the periphery of the consolidated area, loss of pleural line, lots of coalescent B lines. Here on the right side, you can see similar picture with those, I don't know if you can appreciate the streaks, kind of linear echogenicity coming and going. These are fluid bronchograms. And here, the right posterior, upper posterior, as if you're scanning a liver. So this is complete hepatization of the lung, loss of pleural line. You see those white things coming and going. These are dynamic air bronchograms. And here you can see arborescent air bronchogram like tree branching. This is actually classical textbook picture or like videos of pneumonia. And again, on the posterior, on the left side, similar picture, as if you're scanning a liver, lots of air bronchogram, dynamic and static as well, with arborescent distribution and fluid bronchogram in this area. If you look carefully here, you will see floating lines like threads. These are fluid bronchogram from fibrin threads and also from inflammatory exudates into the pneumonic patch, if that makes sense. So when I scanned this baby, the X-ray didn't tell me much about this, what's going on. So this baby has ongoing severe pneumonia, despite the fact that had completed 2 weeks of heavy antibiotics. So at that point, we actually had, so this is kind of a summary of pneumonia features on lung ultrasound, if you like. And so we had urine came back at that point with CMV positive, and then we sent urine, respiratory secretions for CMV, and that came back positive for CMV as well. So we thought, okay, what's going on? Is that an invasive postnatally acquired CMV? Do we need to treat that one? So we gathered kind of information. So if you look back on the bone marrow, you can see there was complete pancytopenia. There was neutropenia, anemia, and thrombocytopenia. Thrombocytopenia actually persisted despite changing the line, giving the antibiotics, giving CSF. The lung, as we can see from the lung ultrasound, there is severe pneumonia, plus the positive respiratory secretions as well. Not responding to regular antibiotics. The LFTs we had at that point, GGT was high, EST, interestingly, was normal. Baby didn't have colitis because the baby was nil by mouth at that point, but there was no features suggestive of, pneumatosis or things like that. No bleeding per rectum, nothing. at all, but baby was sick at like, you know, like anything. And we thought we were going to lose this baby. So we thought about treating this postnatally acquired. Mom had IgG positive. The Guthrie card we sent to check the blood spot for CMV, but the baby didn't have this thrombocytopenia at all from before, and I will show you. So we sent the viral load before commencing the ganciclovir, and that was 34,000 plus. Is not the highest. We've seen higher than that before, but baby was symptomatic enough for me. So we commenced, we discussed with ID team, discussed with the family, the risk and benefit of this, and they wanted to give it a go. So we commenced IV ganciclovir for that baby. Actually was almost 2 months old. And in 5 days, FI2 came down to 60%. Started some feeds. Baby started to become more stable clinically, and commenced feeds. And then baby actually within 10 days was on full feed. So then we switched to oral ganciclovir for another 2 weeks. We've been guided by ID team, and I will give you kind of some thoughts about CMV treatment after that when I finish those slides. So in total, we give 4 weeks. Then started DEX again in the 3rd week. Baby was extubated within 3 days to GPAP, then CPAP. Viral load after the 4 weeks was very, very low, and the blood spot card tested negative. So this is again the summary of the bloods. When we started here at that point, and you can see that changes in the platelet count. It was, as I said, it was normal, and then started to drift here, and then picked up again to normal and never came down again. CRP remained less than 6. Only during 3rd week of ganciclovir, baby had some clinical deterioration, was screened, and blood culture grew staph hemolyticus, and that was treated. So you can see here the trend, the kind of the blue line is a platelet. You can see it was okay, and then started to drop, and reached a nadir around 4th of August. The lowest was 13, and then when we started, it started to pick up again. And this is all microbiology. Initially staph capitis, that was treated, and then urine for CMV was positive. ET secretion was CMV positive as well, and CRP wasn't quite helpful, to be honest. And then after that, we repeated the lung ultrasound for that baby, and you can see the massive difference here, almost back to normal with just few B lines because of chronic lung disease. So this baby actually remained very well, transferred from us to Edinburgh because parents had an extended family there, so they wanted just to move closer to home, was weaned to high flow, and then transferred back to Borders after that. And she's about to go home on just low flow oxygen. So these are actually very interesting articles about postnatally acquired CMV. There are some reported cases, and this one here is the one we use. That's a group from St. Mary's. I'm sure some of you on the call already know those excellent people. So we actually contacted them for some advice as well. And we used their protocol for treatment. This is what they suggested as a flow chart in this article. I would recommend everyone just to have a look on it. It's really interesting read. And then you treat, and you be guided with a viral load and the response, clinical response. Some babies actually required longer treatment. We had a similar case with our colleagues in the Children's Hospital who required 6 weeks of treatment. And you just monitor for obviously ganciclovir or the ganciclovir itself can cause neutropenia, so you need to monitor your white cell count, LFTs, and renal function, and you can give GCSF or stopped temporarily if there is a severe drop of white cell count. Yeah, so in terms of kind of neurodevelopmental outcome, from literature, they said it's not as bad as the congenital. In fact, it's much better. And we obviously, this baby will be followed up for neurodevelopmental outcome anyway in the clinic. And also we referred for extended audiology screening. So, yep, that's it. So I'd like to hear any comments. Mark?
Well done.
Hi, yes, was there any like hepatic picture on biochemistry that could have aided suspicion of this, for example?
Only GGT was slightly raised to like 200 something, but AST was normal, never actually went off. And that was just really complicating factor to us. There was no colitis picture. So in this particular case was invasive pneumonitis and invasive bone marrow, the two organs that actually that we could see on that baby.
I see, thank you.
Thanks. Fasil?
Excellent presentation, lots of great learning points there. I just wanted to ask, do you think, because this baby had a course of steroids that earlier on, do you think that may have aggravated a sort of low-lying sleeping CMV? Because I remember a similar case where I discussed with Evelina, pathologist, the finding of CMV in a patient who had very severe lung disease. This actually was more of a term baby who also had some gene mutation that predisposed to pulmonary hypertension. And he said that it's actually a fairly common finding in babies who've been ventilated for a long time. Regarding that, and it's such a common finding that they do not normally necessarily attribute the lung disease to that, but also say it's just something that may just be resident there. Clearly, in the case you said, the intervention made a difference. The baby got better, the blood parameters got better. The ultrasound findings suggested that there was a pneumonitis kind of picture. So in this case, clearly this was a pathological CMV, but I'm made to understand that not all cases necessarily with CMV findings in the lung necessarily indicate pathology.
Yeah, absolutely. You're absolutely right. I believe when I just went back and through the timeline for this baby, I think when she had the second course of DART at the tail end, when oxygen started just to go up a little bit, I think you're absolutely right. The CMV could have just flared up, and that around that time she started to have the borderline thrombocytopenia, was just around 150, 140. So it could have, aggravated the CMV, absolutely. The problem is, when do we need to screen for postnatally acquired CMV? Do we? What actually I'm interested to know from the group. And Aniko, if you want to tell us a bit more, please.
Sorry, it's not Aniko, it's me, Jay.
Jay.
I'm just using her Zoom access. But yeah, I think, I know these people personally who wrote this review article, and St. Mary's is one of the biggest centers looking after congenital CMV infection. But I wanted to just say exactly what Tosun said as well. I think it's very important to understand that CMV is such a ubiquitous organism, is present in almost every neonate by the time they leave the NICU. So we normally don't train to treat them until it's unless it's a congenital CMV or there are signs of end organ or organ damage or organ infection. But having said that, what we tend to do is every baby who gets the DART or the postnatal steroids, we screen them beforehand with CMV and other conditions, other infections before we obviously treat. I think most of the places do the same thing. But you asked about screening of CMV, so that's why I wanted to say. So normally we would screen every baby who is born preterm at less than 32 weeks, or babies who are less than 1.5 kilo. We will do an admission a screening test for all those CMV. It's just a saliva swab, so it's very simple to do along with the other admission swabs. But also we tend to do a screening before we start a DART regime, which happens very rarely nowadays, but still that's something that we always tend to do.
Oh, that's very interesting to hear, actually. So for every baby who's going to commence on DART, do you do that?
Yeah.
Oh, that's very interesting, because I think
I think it's very important to, as you clearly demonstrated, because if you do a DART, the CMV kind of rejuvenates itself. So because of the suppression, obviously. Absolutely.
That's what we are. I think we are kind of proposing this practice to be changed nowadays here in Scotland. So there is an update of the guidelines after these 2 cases with us, and in the Children's Hospital we had in 3 weeks apart those 2 cases. So we're going probably to change our practice to do that kind of screening before DART. And I know some units like yourselves screen on admission, but just to the difference between congenital and postnatally acquired. Usually the first 3 weeks is congenital, after that is acquired. So perhaps
we tend to do the screening before we give the first milk feed from mother.
Okay.
So at admission, basically.
Okay, that's really good to hear. Okay. Thanks, Jay, for sharing your experience with us. But to me, I mean, the lung ultrasound is really striking because the X-ray didn't tell me much actually about what was going on with the baby's lungs. So that was quite striking to me. So any other comments, or anyone want to share any experience? Yeah, Vikash, please.
Thanks for such an interesting presentation, Mahmoud. Sorry, I didn't join from beginning, but I do understand that, I did join when you went to 51 days of life. So I do understand it's a preterm baby probably who had a postnatally acquired CMV. And we have come into few similar cases where postnatal acquired CMV pneumonitis or CMV enteritis, and you pick them up, they do very much mimic people think in terms of bad BPDs, and timely diagnosis do make a difference. Only my question is in terms of this postnatal steroid, and a lot of units I know do congenital CMV screening for particular criteria, as Jay was mentioning earlier, and a lot of units are moving towards it. Postnatal acquired CMV is almost ubiquitous in terms of particularly moms who are breastfed. The thing is that, do you think this postnatal steroids is immunosuppressive, a particular DART therapy? And do you think because the dose we gave, it was about 0.86 milligram per kg cumulative dose. And is that enough to flare up? Because I've looked into evidence for that and I couldn't find. So the minimum doses which I have found in terms of immunosuppression would be at least 300 microgram per kg per day. And this dose doesn't seem to be like immunosuppressive to me.
Yeah,
I don't know what your other people think about it.
Yeah, it's a good point, because the short answer is I don't know, but could have precipitated for the CMV to flourish a little bit. I don't know, to be honest, because again that was a second course rather than the first course. But you're right, the dose is not actually very massive. And the other case that the Children's Hospital have in Glasgow here, when they diagnosed and started the treatment, they actually gave DART on the same time, along with a ganciclovir to just as a rescue DART, because the baby was just about to die in 100% and not responding to anything. So they commenced the ganciclovir along with the DART at the same time. Whereas in our case, we opted to give the ganciclovir first for 3 weeks until we are in a better clinical situation, and then we commence the DART later on. And there is nothing in literature, because I asked our ID team about this. What do you think about when is the best time to start DART if you're going to commence ganciclovir? Do we start same time or do we just wait? Because what they said, we recommend to continue ganciclovir during the DART course to avoid flaring up of the CMV. But they didn't object about starting both together. But if at least you're going to start downline the course, make sure you still have ganciclovir on board to avoid flaring up of CMV. But
so if you're suspecting CMV pneumonitis, right? If you're suspecting CMV pneumonitis, that's the only thing. If you have evidence of end organ involvement, particularly if you do lung ultrasound, see evidence of pneumonia, which is not explained by bacterial pneumonitis, then you think in terms of, I understand that from point, but my point of view is because somehow in the presentation I was getting the impression that your CMV was flared up due to DART. So my question was whether it was a coincidental thing that you picked it up, or probably because that should not, because again there is no contraindication for vaccination. I don't know, people stop avoid vaccination few weeks after DART. Again, there is no evidence for that.
We'll be interested to hear from the group. I don't know.
So this is the common questions keep on coming up again and again.
Yeah, absolutely.
And I looked into it, dig deep into it in terms of for clinical practice, not for presentation or anything. And I couldn't get any evidence. For a steroid to be immunosuppressive, it has to be particular dose, and the low dose DART is not immunosuppressive, according to my knowledge, and I would learn to be appraised about it.
Yeah, I totally agree, because and it's more like cumulative dose rather than a single course. Yeah. Lawson?
Hi, I'm just sort of curious about your use of GCSF. And it just took me back to the Programs trial, which I think was in 2008, 2009, and which didn't show any evidence for improvement in babies with neutropenic infants, for improvement in their sepsis outcomes. And actually a more recent study going back a few years now, which was published in the American Journal of Perinatology, also looking at effectiveness of GCSF in hospitalized infants. Not only did it not show any benefits, but they said, yes, you got hematologic recovery, but there were increased odds for mortality. And it's recommended that should not be routinely used. Now, I'm aware you didn't use it routinely, but was this sort of back to the wall, we have nothing to lose, let's throw everything at this baby, rather than evidence-based?
Yeah, totally agree. Absolutely. I mean, sometimes you just have to use your gut feeling and your experience. It's not completely evidence-based, but that baby was, like, as I said, was dying, had platelets of 13, neutrophil count of 0.4, and you're not winning. You have tried all the antibiotics you can think of. Sometimes you just add things to the mix and hoping that something will work. I totally agree with you. There is no kind of strong evidence about this at all. Do you use it at all, Dawson, or do you think you could have used it in this scenario? Dawson, can you hear me?
Yes, I can. Hello?
Okay. So sorry, I was saying it's just it was really difficult situation when we were there at that point. So we just had to use it and throw it to the mix, even if we don't have a very strong evidence, because sometimes you just your back is to the wall and you don't know what to do. And
I completely get that, and I think we are all rather guilty of doing that. in the neonatal intensive care arena. And you see the numbers go up and you feel good about it.
You feel good,
but actually,
is it working for the baby or not?
Is it working? Yes, we don't know. Yes.
Okay, thanks. So anybody else using kind of routine screening for CMV before DART in their units?
No, Mahmoud, we don't use that in Aberdeen, but it's actually a good idea to do. I would say that is reasonable, but we do test the babies who feel IUGA. I actually been heavily criticized by colleagues. I asked to do the CMV urine for the full-time baby or 37 week that he had very early jaundice, but that was hemolytic jaundice. And I just felt something not right. And the baby actually had congenital CMV. So that was something, on the top that they had, the hemolytic disease. Baby had CMV. And, but I think it's a reasonable practice, at least to assure that we don't have a CMV. And in fact, actually, I just have a kid with very similar on high flow, 70% oxygen, 38 weeks now with the X27, 26 week, very stormy start of life. Maybe I should check that.
Jennifer?
Hello. Hi there. I was just interested, so we don't screen for CMV before we start steroid at the moment. I'd be interested to hear from those who do though, what do you do with that result? I mean, maybe somebody's already said it and I've missed it, I'm sorry, but do you not give steroid, or do you give steroid and valganciclovir, or do you give steroid and keep a lookout for the baby getting on well? With the knowledge that they might reactivate CMV. I just interested to know how that bit of information is used.
Yeah, absolutely. Unfortunately, Jay, who was on the call, he just left. But I think this is what they suggested, the St. Mary's group in their pathway. If you when to treat is when you have criteria of invasive organ affection of CMV, more than one, like bone marrow, lung, liver, colitis, all these kind of things, and biochemical evidence of LFT's derangement, for example, then you should think, and clinically baby is unstable, obviously. But I think it's a question that we need to think about when we screen what we're going to do with the result if the baby is actually asymptomatic. And we know from literature, not all postnatally acquired CMV are symptomatic. So we just need to weigh the kind of the idea, what are we going to do when we know about that. I think it's a valid question. I don't know if anyone on the group has answer to that. So just do you do that routinely in Homerton?
No, Mahmoud. We don't routinely check it. We don't.
Okay, so I think it's probably unique to St. Mary's and Queen Charlotte, because I know their population. It's very. I used to work there before, so I know the population. You get lots of admissions with CMV there, so that perhaps that's why. And perhaps we should think about demographics in our population. If it is actually high incidence or relatively high incidence, then perhaps there's something we should adopt. Perhaps it's just population-based rather than universal screening. Okay. Maybe we'll just speak to the guideline group here about this and see what they think. We're going to update our guideline, I think. Mark?
Sorry, I might have missed this. How did we exclude congenital?
Yeah, so the baby started to develop the symptoms almost 2 months old. So that was after 3 weeks of age. And also the blood spot was negative for CMV.
Okay, thank you. And great presentation, thanks.
Oh, thanks, Mark. Thanks, Mark. Okay, thanks everyone for joining. And that was a really useful discussion. Okay, thank you. We'll see you next week.
Thank you.
Thanks very much, Mahmoud.
Thank you, Mahmoud.
Thank you. Bye-bye.